I'd like to welcome you to another episode of Mission Matters. My name is Adam Torres, and if you'd like to apply to be a guest in the show, just head on over to missionmatters.com and click on Be Our Guest to apply. All right, so today I have Delbert Arrendale on the line. He's founder and CEO over at Interoperable Systems and Images. Del, welcome to the show.
Thank you. Thank you for inviting me.
All right, Del. I've been trying to get you on the show for a long time. This is maybe 2 years in the making. So finally got you on. We're going to be talking about transforming healthcare through AI and patient-centric interoperability. But before we do that, we'll start this episode, Del, the way that we start them all, with what we like to call our Mission Matters Minute. So Del, at Mission Matters, our aim and our goal is to amplify stories for entrepreneurs, executives, and experts. That's what we do. Del, what mission matters to you?
Well, making patients better by them spending less money and improving healthcare overall.
That's a big mission. Love to have you on. Love to hear how you plan on doing that as well. But I guess maybe just start kind of at the beginning. What inspired the mission behind ISI and how your journey led to you wanting to be in this pivotal role in digital health? Like what led to this?
Well, I've been in healthcare for over 30 years and been involved in several different companies engaged in healthcare workflow and clinical documentation for patients and for physicians and the providers around those patients. So I've got a vast background in providing and developing applications for customer-focused use, patients as well as doctors. And one of my friends, a very good friend of mine, his wife got injured in Vail, Colorado on a ski trip. And that resulted in ambulatory care. She ended up going to 3 different locations and having x-rays and MRIs taken at each place. And by the time her husband got out there, he had to literally go through snowstorms to capture data over a period of 3 days when it just wasn't available online. So he brought this problem to me, and he and his doctor, the doctor that actually was assigned to his wife, they were thinking, my goodness, this is just not good. There ought to be an easier way to get clinical data to the doctor that needs it in time for them to be of value to them. So they brought that to me, and I looked at it and I thought it was a great idea, and here we are.
Wow, that's amazing. And so how many years ago was that roughly?
That was about 4 years ago.
Yeah. And so talk to me about the buildup and what you've done to start, solving this problem. Let's get into the company itself.
Right. That's a great opening for me because it's indicative of the problem itself. The real problem is that clinical data, especially imaging, MRIs, CAT scans, that sort of thing, it's just not available. Vendors pretty much shut that data down outside of their walls. So they call this siloed data, and it's such a big problem. It costs a lot in duplicate testing. It costs a lot in wellness, because doctors don't have the right information to make a diagnosis. So we just tackled that problem head on. And in my business, my core business at Arrendale Associates is clinical documentation. And the one thing that we lacked was the images themselves. We'd always had interfaces to PACS systems, but we didn't get the images. We just got the radiology results. And those went to the doctors, and that's generally good enough. However, if you're an orthopedic surgeon and you're looking at a knee that may have had prior injuries over the past, you may want to look at imaging that's 2, 3, 4, 5, 10 years old. And without that proper perspective on the injury itself, it's hard to make a correct diagnosis and even have a plan for making everything better. So that kind of drove me into doing the research that I needed to do in order to understand if there's in fact a market for this. And that was proven to me because early on, almost all of our investment capital came from orthopedic surgeons and doctors because they see this problem every day.
And so looking at, and I'll go a little bit further in the image side. Could you maybe give a use case of what that could look like? Because I want people to have a really clear, vision of what they're dealing with. So it could be the orthopedic surgeon example or another, but talk about why the image is so important. I want people to really get that.
That's a really great question, and I'm a perfect example. But almost everybody that I know has a story that they can tell about not having the right data at the right time. And in my case, I had a knee injury, I don't know, 15 years ago, and I had some
Yeah.
X-rays of that knee, and I even had an MRI on that knee. And then about 5 years ago, I re-injured that knee to the point where I had to have knee surgery, and none of that documentation was available.
Mm.
And the surgeon told me at that time, golly, if I'd had that data, I could have maybe done something a little bit different or prescribed a different solution for you. Where in fact, what he had to do was, order an MRI, review it, and then go look at it. And basically, he did exploratory surgery in my knee to figure out exactly what had to be done when he could have maybe gone right to the source of the problem earlier and faster, maybe even cheaper.
So even just the expense of having these MRIs done and otherwise, like, and sharing them from system to system, like that's a big cost, right? Like overall.
That's probably one of the largest costs in healthcare. CMS and Health and Human Services, HHS, are directly addressing that as one of the prime movers in the cost of healthcare, is duplicate testing. So, for example, in the case of my friend's wife who got injured at Vail, she had, an MRI taken at Vail Valley Medical Center. Not having that data at each location, everybody did an MRI. So 3 times MRIs were taken, and 2 of the times probably not necessary. And 2 of the cases, full body scans, very expensive, because the injuries, were from the neck all the way down to the toe. So there was a lot of problems in that, and that does drive the cost of healthcare. But that happens not only in imaging, it happens in blood work. It happens in tests that they order, just simple tests, sleep studies. I mean, things that you wouldn't even think would be involved. Whereas if you have that data in a warehouse in the cloud and I control it, I'm the patient, then I can direct where that information goes and what provider, what physician gets it at any time.
Yeah.
And so that's one of the key goals of CMS, is to put the patient at the center of their medical record and put them at the center of their clinical care when it's needed.
Now, I know one of the things that you're doing in terms of focus is you're focusing on the rural communities. Why does this matter?
That is so important, and what a great question. It matters because the rural community is poor. Not only are they poor, they're unhealthy. It's a very unhealthy community, and it's prone to injury because there's a lot of farmers out there that get injured, and they're 30, 50 miles away from the nearest person that can take care of them. So the rural community is underserved, it's underfunded. HHS is trying their best to provide the tools and keep critical access hospitals open and to provide, critical points of care in communities. And they've even come up with special programs to do this. But the big players, the Epic, the Cerner, those big players, they focus on urban communities because that's where the big health systems are. And, they can make a $400 or $500 million sale as easy as they can make a $200,000 sale. So if you're in business of selling large health systems and maybe the larger university health systems, and you've got a chance to focus your sales energy on that and not go to these little communities, then that's where you're going to focus. So what happens in the urban areas is that they have all the money and all of the best technology.
Yeah.
But in the rural areas, they don't have it.
And so when we think about, I don't think I can let somebody off the line nowadays without bringing up AI. How does AI play in all this?
Yeah.
Like, well, how's this making your life easier, and how's this, or not? How does this play into this whole system?
It's just now entering healthcare in a big way, and it's one of the main drivers of the new HHS initiative to provide patient-centered care and to utilize AI more to help patients manage their own health. For example, we're going to use it in a couple of different ways. We're going to use AI to help us what we call stratify the sickness level of a patient. So patients come to you, they're either really well, they're somewhat sick, or they're very sick. And those different conditions determine the cost of care for that patient. And for example, the sickness conditions, you can have multiple what we call morbidity. And a morbidity is a disease that can kill you. For example, heart disease, kidney disease, lung disease, obesity. So there are things that can make it very expensive for the government to keep a patient healthy if they have one or two or three or more of these morbidity conditions. So what AI can do is it can evaluate, it can analyze your clinical data, it can analyze your personal data, like how much do you exercise, how healthy are you, what are your eating habits, and it can look at your age, and it can look at your history, your medical history, and it can do predictive analytics on how long am I going to live if I keep going down this path, and what could happen if I changed a few things in here and made it easier for me to live longer because for example, I stopped smoking, or I don't drink alcohol, or I don't eat as much. So AI can do a lot. It can do diagnosis. Sometimes it can diagnose diseases that are rare or conditions that are not well known by the doctor you're seeing. So it can look at all of this data, and it looks at it not just at real time, but it looks at longitudinal data. So it can look back into the past and look at data in the history of your healthcare, and then it can do predictive analytics on where you're going to be in the future. But it can also, right now, it can diagnose you as one of those conditions, those 4 conditions I told you about. And it can recommend changes in your lifestyle to make you cost less money to the health system and make you better as a patient.
I wanted you to get further into this concept, because it is a different concept, and that is of what I would say healthcare has been in the past. And this is where, with your system, because patients have control over their data, they have control over their records. Really, they become also potentially more active participants in their overall health, because they're responsible for those. Like, how does that moving it to like a patient-centric kind of modality in that, like, how do you see that playing out? Because that's different.
Right. That was always a core feature of Arrendale Associates. You know, the company that founded ISI and made ISI a new division of AAI was always in clinical documentation, putting patients in the center of the care. In the old days, before we had this term called collaborative care, we had concurrent review. And concurrent review came about 15, 20 years ago. And what it allowed was, from an EHR, for multiple people to be looking at the same information at the same time. So when in the collaborative care world, the patient is at the center of the care, and the doctor is not at the center of the care, which is a big change, because up until just a few years ago, the doctor was always the center of the care. Everybody knows their primary doctor, and a lot of times their primary doctor will recommend another specialist to them. And when they go see the specialist, those two don't even talk together. And the specialist might prescribe physical therapy, or they might provide some kind of home health care. They might even recommend that you have some mental health. So all of that, when you put all of that together, that becomes a care team. And when the care team is collaborating with each other on the patient at the center, then they can come up with a better way to make that patient better. And also eliminate duplicate testing, because they're all in the same chart, looking at everything at the same time, and it reduces a lot of cost. And let me just add this to it. Not only is CMS and HHS concerned about individual wellness, but they're really keying in on population health management, because at the macro level, you've got the patient, but at the macro level, you've got the community. And at the macro level, you've got the patient. So as I understand the wellness and sickness of the patients in the community, I can diagnose and I can see trends that you may not see if you're only looking at the patients, and you're not able to crank out a lot of data points on a lot of different patients to maybe determine whether there's something in the environment, or something in the lifestyle, or something in the culture that may causing people to have a common illness that's not known anywhere else. So population health management is where the whole country is heading, and that's going to really drive down the cost of healthcare over the long term.
Where's the company at now? When we talk about things like transforming healthcare, like where are you at now? Tell us about maybe the rollout and plans for the future.
We're now getting ready to roll out. We're seeking some funding right now. Arrendale Associates purposely made ISI a different company. We decided early on that it would be good to use AAI's foundation, which means we have people, we have processes, accounting and HR, we have technology, we have infrastructure, we have developers, we have teams around the world, and we have teams in the US that can do development work. So when we developed this application for ISI, our platform is called Health Spectra AI. And the AI component of that is really important because it incorporates the data that's collected into the AI for doing the wellness and the predictive analytics and the longitudinal data analytics and all of the other stuff that goes along with the platform itself. But more importantly, by making ISI a totally new division of Arrendale Associates, it enabled us to become almost like a startup, which we wanted to be like I don't know how many of you are familiar with Skunkworks, which was a division of one of the big aerospace companies years ago, that they had the Skunkworks department with a whole bunch of scientists in a corner that would develop something like stealth technology. And they did it outside of the constraints of the main company. So we decided to do that with ISI. We gave it its own name. We gave it its own charter. We turned it loose. We let people develop it. It's now a very agile company. It can change directions without having a company bureaucracy oversee all of that and make it hard to change directions. So we see ISI as making a big difference in healthcare because it's going to focus. Its mission is to make people better, and it's going to do that by focusing on the niche market, which is the rural communities in the U.S. And there's like 50 million people in rural America that have inadequate health care. It's a big problem.
And when we say rural, can you define that like roughly? Like when we talk about rural, it's outside of all the major cities, right? I just want to get a feel.
Yeah,
when in healthcare terms.
Yeah, in healthcare terms, a community that has less than 15 doctors is underserved. And there are there are hundreds of these communities in the U.S. that have less than 15 doctors. It takes 15 doctors to support 5,000 Medicare patients. Wow. And there's a ton of Medicare patients out there in rural America. So these doctors can't participate in collaborative care. They can't participate in patient-centric care. They can't get involved in population health management because they simply don't have the tools to do that. So what ISI was chartered to do was to develop these tools and to develop them in tune with HHS objectives. And HHS has some very clear objectives, and the major vendors are still focused on the major problems, whereas the minor vendors like us are focusing on the niche problem in rural America. So I think that if you're looking at a population of under 50,000 people within a health radius, that's rural America, and that
and you
America
said over 50 million people fall into that bucket, so to speak.
50 million people fall into that bucket in the United States.
Outstanding. That's a lot. It's a lot of lives, a lot of individuals who can benefit from this and who deserve better healthcare, right? And a better healthcare experience. Well, Del, man, this has been great. I got quite an education today, and I'm sure our audience did as well. What's next? What's next for you? What's next for ISI?
Oh, wow, that you just turned me loose here.
Yeah.
HHS just had a technology press release on July 30th, and in that they released their latest initiative, which is turning loose interoperability, which has been around for about 8 years now and gotten nowhere because vendors still refuse to make it easy to get patient data out of their systems. So what HHS is doing is they're speeding up this process by saying, look, vendors, if you want to participate with Medicare and Medicaid in the future, we're going to develop interfaces for you that you need to deploy inside of your applications. And this is just coming up. This is coming to fruition by the end of this year. But for example, there's this program called Blue Button. And Blue Button is an API that that HHS is writing for vendors to deploy inside of their application that will allow vendors that also have that application to For example, a doctor, you see a doctor,
Mm-hmm.
the doctor's talking to the patient real time. The patient says, I'm in this health system over here. I've got all of my clinical data over there. The doctor can push a couple buttons and voila, that data will come over to that doctor. Today, that's not even possible.
Yeah.
Even with interoperability, because there's so many constraints to today's interoperability. So with Blue Button, for example, and also HHS has decided everybody has a smartphone these days. They want the patients to now use their smartphones first. When they like go into a doctor's office, what's the first thing they do in that office? They hand you a clipboard. So HHS has this program called Kill the Clipboard. And killing the clipboard means that I can take my smartphone and I can push a few buttons and I can push another button, and all of my data, my insurance information, my medical records, my personal health and wellness scores, all of the stuff that you check off on that list, my meds, everything that you check off, family history, all of that stuff automatically goes up and eliminates the clipboard. So isn't it going to be nice to be able to walk into a doctor's office and they don't hand you a clipboard? Now they send you to a kiosk, you push a few buttons, make a few pushes and buttons, and there it is. So that's a big initiative of CMS. Another initiative of CMS is to allow medical data to move seamlessly between systems, health systems. Whereas today, they've made it so bureaucratically impossible to do that. CMS came up with a new program to reduce the bureaucracy that's involved in moving clinical data. They have a whole initiative around this. So in order to make this work, they have to reduce the bureaucracy. For example, if a doctor wanted to have an interoperable interface with a clinic someplace or with a hospital, they had to have a separate agreement, HIPAA agreement signed by the doctor and the place in order to just let the data flow. Whereas with the new HHS APIs that they're developing, and ISI is in line right now to develop all of the applications around these APIs so that we can seamlessly interface and be part of this big vendor world, the Googles and Microsoft and all of them. So that's where we're headed, and it's exciting. It's very exciting.
Man, that is exciting, and it's going to move things along for sure. When you think about it, because if they want to play ball and if they want to be part of that space, they have to do it now. The one time it does that's interesting. And my little story would be I went to the DMV the other day and I was like, whoa, wait a minute! You scan a QR code now. I was like, oh wow, I haven't been into a public kind of office in a while. That's the first time in years. And I'm like, so when you said that, I'm like, wow, it's gonna be they're catching up. This is good. Kill the clipboard. I'm in. Oh, Del, this has been great having you on the show today, and thanks for the updates as well. How do people connect? How do people follow up? How do they connect with you and learn more about ISI? You mentioned you're doing a raise as well, so a lot of accredited investors that watch this as well. So how do people connect?
Well, you can contact me directly. My name, Del at isi-inc.net. I'm on LinkedIn as Delbert Arrendale. You can find me out there. Our websites, we have our AAI website is aaita.com, and our ISI website is clinical and a business and a consumer. The consumer side is myhealthimages.com, and that's probably a good place to go for the consumer.
Yeah.
But we also have a B2B website, healthspectraai.com.
Amazing. And for everybody watching, just so you know, we'll definitely put some links in the show notes so you can just click on the links and head right on over. And speaking of the audience, if this is your first time with Mission Matters and you haven't done it yet, hit that subscribe or follow button. This is a daily show. Each and every day, we're bringing you new content, new stories, new ideas, and hopefully new inspiration to help you along the way on your journey as well. So again, hit that subscribe or follow button. And Del, man, I'm glad I finally got you on. Been a year or two in the making on this one. Thank you.
Sorry about that.